Hello, good morning or good afternoon, everybody. I'm happy to be with you for the second half day of lecture. I hope Leonid is in good shape for the translation. Better than me. And I hope that my voice can work from the house. Last on Saturday we was discussing around occlusion, and today we will open a new topic. It is not really new. It is because the problematic of temporomandibular disorders is well known from many years. And it is interesting to separate in two different days. The topic on occlusion and the topic on TMD. On TMD, because they are not uh, exactly the same. And the relation between temporomandibular disorders and occlusion are not direct. Okay, so TMD is a complex topic, and I would like to have like a goal, uh, pragmatism and efficiency. And I have to start by definition, of course. Numerous years ago, a patient, a young lady, came to my office with a lot of complaints, with a facial pain for many time. And she has a small bag with many splints, 18 splints. She saw before me 25 practitioners with many specialists. And she had 18 failures, and she stayed in pain. And you can see here air occlusion with an important open bite. And she had a lot of splints with different type of form. But the problem is not the type of the splint. The problem is the diagnosis. I'm working on temporomandibular disorders topic from many years. I wrote a book in 1992 on temporomandibular disorders, and another one in French in 27. I hope an English version for 2022 on temporomandibular disorders. And between these two books, anatomy does not change. The physiopathologic rules does not change. But the understanding of the problems and specifically the decision making change. I think decision making is clarified. It's clarified. Why it is clarified now? Because the definition is more precise. I said Saturday morning that occlusion is a confusion. Confusion also is a law in TMD. And why TMD is a confused field? The first reason is because it is a multifactorial, complex, etiologic uh, disease. And so there are many elements to take in considerations. The classification for temporomandibular disorder subcategories is very confused, and it stays confused. There are not a very good specificity for the clinical diagnostic test. And paradoxically, there is a wide effectiveness of all therapeutic methods. Everything is working at 75%, but the problem is for the 25% where it is not working. And there is a confused definition. In the TMD field, there are so many papers. It is impossible to read all the papers published every weeks. So many. And so it is difficult. What is temporomandibular disorders? In 2005, I was in a High Court meeting in Australia. It was an inter-academy meeting. There is an academy of United States, of Europe, Asian Academy, South American Academy, and so on. Excuse me. And the lecturer make a conclusion. In summary, for too long time, dentistry has focused on occlusion as a cause of orofacial pain. We need to get occlusion out of our head and think from medical perspective. Oh, do you think that I agree with this conclusion? It depends which sentence. When he said we need to get occlusion out of our head, I disagree. Occlusion is in the center of the dentistry, and I am a dentist. And I am thinking in medical perspective from many years. It is a provocative sentence. I refuse it. But I agree with this. And why I agree with this? And words are important. I agree with this because he said he was speaking of orofacial pain. Of course, occlusion is not the cause of many orofacial pain. Who claims to treat trigeminal neuralgia, migraine, cluster headaches, myoclosal adjustment. Okay. If he said TMD, in place of raw facial pain, the problem will be different. And today I would like to speak about TMD. The TMD definition is a 1993 collective term embracing a number of clinical problems involve masticatory muscles, temporomandibular joint, and associated structures, or both. It is very unclear. So the definition from Frankton in 2001 is better. The definition from the American Association of Dental Research stay in the same confusion by this sentence, all associated tissues. What means? I understand musculoskeletal, okay, and neuromuscular. Both that involve temporal mandibular joints, okay, masticatory muscles, okay, and all associated tissues. What is this? What he wants to know, to say? Is it parotid problem, sinus here, lymph nodes problems? What means associated tissue? It is a window for confusion, and big confusion. Sandro Pala from Zurich proposed at the beginning of the 2000 a definition of TMD like a myoarthropathy of masticatory system. That is very clear. Myoarthropathy, muscles and joint of masticatory system. So it is not the parotid. It is not a tension headache. It is not a neuralgia. It is not muscles pain in the cervical region. It is myoarthropathy of masticatory system. And with this definition, we can go with on a good way, in a clear way. The epidemiology of TMD is summarized by high prevalence and low incidence. That means that it is very frequent, but rarely with a bad prognosis. Very frequent is around 10% of the population. And it is the second most common musculoskeletal condition after chronic low back pain in general. Okay, now we have a definition. We know that in medicine it is diagnosis first. Also, we need to join to the definition criteria of diagnosis. to obtain a positive diagnosis. Not just a soft hypothesis. Myoarthropathic means joint and muscles are concerned. And we have clinical TMD identification by three cardinal signs. Sorry. Sound. TMG sound. Click, crack, crepitation. It is a positive sign of TMD. When you have a click, you have a TMD. It is not necessary that it is a very, very important problem, but it is a TMD. Algia, pain, but not all the pain on the face. Pain increased by mandibular function. That is a positive sign of TMD. And dyskinesia. It is anormal mandibular movement, deviation, deflection, limitation. When you have a deviation of the open movement, when you are opening like this, you have a TMD. And it is S like sound, A like algia, D like dyskinesia. The acronym SAD. Very simple to memorize. When you have one of these clinical categories, you can put your patient on the box of TMD. And it is simple and clear. We have a simple definition. We have a simple signs of identification. So TMD is not very complex. If you have at the base, like a stone base, simple things like this, definition and identification, we are in a good way. Sound, TMG sound, facial pain, but not all the facial pain, increased by function. And normally I tested the video this morning, it was working. No, it is not working. The opening movement is not right. It is with a curve. And there is a little sound. You cannot hear it. But it is a sign of dysfunction. The three signs SAD are very important and very simple. In 1982, Dworkin and Laresh proposed research diagnostic criteria for temporomandibular disorders. It is very famous, and it is the base of all scientific methodology on TMD research from this day. And they said that there are a mechanical structures that we have to analyze, and you call it axis 1. And we analyze this by the physical assessment. Okay, So this one was classical. But he said there also another point, another dimension that we have to analyze. It is a psychosocial status, and he called it axis 2. But to observe a click, for example, is not enough. We have to understand the patient who is behind this clinical signs, and to understand his psychosocial situation, especially from emotional point of view. But so in 1992, and from 1992, it was very classic to analyze TMD with axis 1 and axis 2. Do not hesitate to to give me questions during the presentation. But in fact, it is not enough, because there are not only two dimensions in the etiology of the TMD. And in 1980, more 10 years before, Torre Hanson proposed a three-dimensional etiopathogenic model. In 1992, the group from Marseille integrate the three-dimension etiopathogenic model. And of course, we have the axis 1 with a mechanical dimension. It is a somatic local aspect, skeletal type, TMG, occlusion. Of course, also axis 2, which is a psychosocial dimension. It is a psychology of the patient with its consequence on the behavior of the patient and about modulation of pain. But there is a third dimension. The third dimension is a biological dimension. It is the terrain or the field of the patient. Somatic general aspect. Is it a young woman? He is an old man. Somatic general aspect concern hormones, genetic, systematic disease. For example, hyperlaxity. So we have a 3D etiologic model, and we must understand our patient following the three dimension, not only the psychology, not only the mechanic, but the mechanic, the psychology, and the biology together to have a well understanding of our patient. In 2014, Schiffman and many authors propose an evolution of this RDC-TMD to DC-TMD. DC means diagnosis. RDC, it was research criteria for diagnosis. Now, it is for diagnosis, for not only for the research. And there are only two axes in their concept. But the authors open window on a third axis, axis 3, with something like relevant biomarkers. It is like biology. And eventually a fourth axis concerning globally some clustering models. So this group is able to change. I'm happy for this. 3D is complex. The face is complex. There are a lot of things around the teeth. And if you try to explain temporomandibular disorder by a simple binary model, one cause, one effect, you are completely wrong. It is a multifactorial etiology. You can have bruxism, you can have stress, you can have a systematic joint pathology without occlusal disorders. And you, in another model of type of case, perhaps you can have a strong occlusal disorders, which TMD disorders, mechanical TMG disorders. And it can be another form of other type of patient. So it is necessary to observe our patient, to analyze all the parameters, to go for treatment in the more simple way, the less invasive way. And it is when the etiology is multifactorial, it is a difficulty for the understanding of the etiology. That is a negative point. But there is a positive point that we have many windows for treatment. You can act on occlusion, or you can treat occlusion, or you can treat TMG for the blue case. Or for the red case, you can just decrease the bruxism or decrease the stress. To increase the health of the patient. Many options for treatment. There is a large consensus to recognize that the benign model failed to explain TMD and to recognize the multifactorial etiology. In the world, everybody is agree, almost everybody. It is a functional disorders. That is very important to understand. Myoarthropathy is a functional disorders. And the treatment must be oriented to improve the functional capacity, using the capacity of adaptation of the patient. more using the capacity of the dentist to change the occlusion. Understanding the patient is put the patient in a cybernetic system, which was described by Rudolf Slavicek, where the environment, one organism, it is a patient, the mandicatory apparatus, masticatory system of the patient, is piloted by nervous central system with this somatic part and with this psychologic part. The masticatory system has structures, skeletal and the joint structures, neuromuscular structures, and teeth and occlusion. That is the structures. And the functions. There are many functions, not only mastication. A lot of function. Rudolf Slavicek, who is here, and we was in the garden of the Anthropologic Museum of Vienna at this time. Rudolf Slavicek said we need a diagnosis. No treatment without a clear diagnosis. It is like when you are on a boat, before to go, we have to know where you want to go. Okay? But before, we have to know where you are. It is a diagnosis. Okay. Make a diagnosis. To make a diagnosis, we need a classification. Because diagnosis is like different boxes of different disease with different signs to put the patient in one box or sometimes one, two, or three boxes. So we need classification of TMD and also of orofacial pain. Okay for the moment? A small question? I appreciate if you give me some questions. The science, it is first to classify. Remember yesterday or Saturday. It is one example of a classification proposed by Deleuze. Thank you. No questions means the presentation was very clear, or the second option is everybody's go away. And it is a confused classification. Muscle disorders classification is not very, very clear. Excuse me. And for the articular disorders, there are disc derangement, okay, growth disorders, trauma, hypermobility, hypomobility. Hypomobility, if I stay on these items, hypomobility is a science. It is not a diagnosis. You can have hypomobility and many diseases. So it is not very clear. And one of the objectives of the new DC-TMD is to propose new classification, but the aim of this article is to present evidence base of different clinical tests. And it is an important point of this article. It is a validation criteria for diagnostic test around sensitivity and specificity. And this part is very good. But concerning the classification is not good. And some authors that you can see here said we have to improve the DC-TMD 1 year after its publication. Look at the classification proposed by DC-TMD. You can have here arthritis. What means arthritis? Arthralgia. It is a sign. It is not a diagnosis. Here we have systemic arthritis. You have disorders and you have disease. That is interesting. In fact, in this classification, this classification mixed primary and secondary temporomandibular disorders. And it is a negative point. So I would like to propose another way. I hope it more clear. First, we have to separate TMD and non-TMD.